increasing. They're available, sadly, because they're over the counter and they don't go back again to the doctor to get a prescription every time, and the pharmacist will sell them. So knowing what has happened is important. So we have a lot of newer calcium channel blockers right now. Dihydropyrimidines are there. Max recommended dose is around 10 mg. Our patient had consumed 275 mg. So the big effect that calcium channel blockers have is a toxic effect on the vasculature and the heart. So this picture that I'm showing you is actually a picture of a cardiac myocyte. So a few of the things that you can see here, you can see the beta agonist receptor on top. You have a calcium receptor. You have an insulin receptor. So obviously, a calcium channel blocker blocks the calcium receptor. Beta blockers blocks the beta receptor. But the fundamental thing that's happening in a cardiac myocyte is calcium has to get to the sarcoplasmic reticulum, which allows contraction of a cardiac myocyte, and eventually you get left ventricular systole. So when this is blocked, that doesn't happen. So we have to use, we have to manipulate the insulin pump to bring in more calcium, and that's how treatment has been advised. You use glucagon, which acts on the beta receptor. So these normal physiological actions of hormones and things that we do is what we manipulate at a much higher dose or maybe a different dose to get it to change. So atenolol is a beta blocker. Max dose is 200 milligrams per day. Our patient had consumed around 500 milligrams. So this is what our patient was. So the one thing that you have to remember really well, which we take for granted, I think, when we do pharmacology, is elimination time. What's the half-life of a drug? So this is the basis of how many times we give a drug in a day. Beta blocker half-life is around 4 to 6 hours, so we give it 4 times. Now you have longer-acting beta blocker. So you have to know, you have extended release beta blockers. So knowing what drug and how it affects the half-life is important. Calcium channel blocker, depending on which one you're using, varies. So if the half-life of calcium channel blockers on general is 3 to 7, but amlodipine is 30 to 50 hours. That's why we give it only once a day. Patients love it. Physicians, easy to prescribe. Once a day, patient is happy. And beta blocker, atenolol, not much used. This patient was using around 2 to 4 hours. So what's the terminal half-life? Basic pharmacology. Half-life is this much. What's half-life? Time taken for the drug to be eliminated to half. So what's the terminal half-life? 5 half-lives. So by 5 half-lives, it will become 1/128th of a dose. So almost 99% will be eliminated. So if you take a half-life of 30 to 50 hours to eliminate amlodipine, 15 to 5 is 250 hours, 10 days. And if it had more permanent action on something, then you can't even eliminate it. I mean, it's already done the damage. So that's how you have to start processing. How long will it take for this patient to come back to normal? How long will you have to continue treatment? All of this gives you perspective. So when we got this patient, we figured out, okay, it's going to take us a week, 3 to 4 days, at least minimum, to get them out of shock. So terminal half-life is 5 times. So any drug, so frequently nowadays for stroke, we thrombolize a patient. And they say, when can I put an IV line? Because once you've given the drug, you can't. So the answer should always be 5 half-lives. If you take for 5 half-lives, the drug will be gone. Now you can poke the patient, put a line. So anything you do in pharmacology, the basis is 5 half-lives. That's why we repeat the drug, maintain serum concentration. But remember, when you're treating toxicity, it's because it's going to last at least for 5 half-lives, other than any permanent damage it does. So how does the CCB work? Basics, again, you have to know pharmacology. So myocardial contractility, it facilitates vascular smooth muscle contractility, and it also modifies the way pacemaker cells act. So what happens in toxic? So CCBs are classified into dihydropyrimidines and non-dihydropyridines. Anybody can name a few? Dihydro, non. There are only 2 drugs on one of the sides. So verapamil and diltiazem. Pharmacology classification, you have to know. And on this side, you have all your dipins, and it's a growing industry. Newer drugs are going to keep coming out. So dihydropyridines block the L-type calcium channel, and the non-dihydropyridines act directly in the myocardium, but there is a certain overlap. It's not a hard and fast rule. So one affects the heart and the other affects the blood vessels. So eventually it reduces cardiac function, lowers BP. So using this normally brings BP down. You use it too much, brings BP down a lot. So here in when you use nifedipine and amlodipine, you get vasodilatation and reflex tachycardia, and eventually it loses the effect of the myocardium is lost. You have decreased inotropy and bradycardia. The other non-dihydropyrimidines causes peripheral vasodilatation, and these are drugs used in arrhythmias. So they reduce inotropy and cause bradycardia as well. So whatever pharmacological normal action we use, they get worse. With one principle you can adopt. Beta blockers, you all know beta 1, beta 2, beta 3 receptors. So wherever those receptors are there, the actions take place. Cardiac decreases myocardial activity, brings the heart rate down, decreases the afterload, causes hypotension. These metabolic effects are lesser, but they're known to cause hyperglycemia theoretically, but we don't see it very often. But at supramaximal doses, you might see an effect. So what is the important thing you have to know? How much was taken? When was it taken? What was taken? In both types of CCBs, you get hypotension. Bradycardia, commonly in a non-dihydropyrimidine. And JV, distension, pulmonary crackle, signs of heart failure, everything that the patient is going into a type of cardiogenic shock. That's what's happening. So patient, as long as they have a clear mental statement, means they're perfusing. The brain is still getting enough blood. If they become drowsy, have seizures, altered mental status, that means the brain isn't getting enough blood right there. So rarely you get symptoms of GI, nausea, vomiting. You'll get that initially, but once really high toxicity sets in, those symptoms disappear. Beta blocker, again, you get a lower heart rate. QRS interval gets prolonged, heart rate comes down, and they may go into blocks as well. And because they go into blocks, eventually they become drowsy, and it's very lipophilic. It gets attached, so you get seizures and delirium because the delivery is slower. And intrinsically, they're sympathomimetic, they get blocked. Intrinsic sympathomimetic activity takes place, but it doesn't manifest because of the overlying cardiac suppression. So our patient had vitals, airway was more or less maintained, saturation was 98, respiratory rate 20, heart rate was 78, BP was not recordable. So very confusing when you see this, all vitals normal, but the BP is not recordable. So this is what happens with these particular drugs. Numbers look quite nice, but BP won't be there. Consciousness is good, patient is looking fine. So the next test that is most useful is the ECG. Before we run into big scans or anything, look at the ECG. So ECG findings in calcium channel blocker, sinus brady, accelerated AV node conduction may be there, varying degrees of heart block, complete heart block could be there, and you may get a sinus rash. Asystole very rarely, but at very high doses you can get it. So this was what our ECG showed. So anybody wants to have a crack? So heart rate was only around 70, and there was a junctional rhythm. There were no P waves, but QRS was quite narrow, and there was a junctional rhythm. The heart rate 70 is actually pretty good for a patient with no blood pressure. But the important thing you have to remember is whenever you've got low blood pressure, your heart rate should have gone up. There should have been tachycardia. You go for a jog, heart rate goes up. You have diarrhea a couple of times, heart rate goes up. Here we have a state where BP is not recordable and the heart rate hasn't even changed at all, 70. That itself is a very poor sign. You should have reflex tachycardia. So our patient, bradycardia, hypotension, and there was a junctional AV block. So remember, when a patient comes in with poisoning, you never know what they've taken. They may tell you it's this, or there may be a suicide letter, or some family might have seen some empty packets, but you have to consider differentials. So what else can cause this? Low heart rate, hypotension, the list is endless. These are just a few. Alpha blockers, digoxin, OP poisoning, cholinergic drugs, opioids, and this list can go on. So it's very important to consider that there may be other drugs as well. So DDs we looked at. Other non-pharmacological DDs are hypothermia, acute coronary syndrome, hyperkalemia, hypothyroidism, glycoside toxicity, beta blocker, any other antiarrhythmic drug can consider this, and even sedative hypnotics, all of them at a higher dose, the patient can look just like this. So that's why you have to keep in mind, are there any other diagnoses as well? And we have a tendency, once you've got history, you have a drug, oh, that's causing everything. So this was our patient's blood gas. This was in the previous hospital, and then our hospital, a good 4 hours later. So what do we see in this blood gas? what do we expect is the question. So before you do a test, always have an idea that this is what I'm looking for. So what you see here can be normal initially. Initial blood gas, bicarb is 23, no acidosis, a little bit of lactate, and then we repeat. Now what's happened is bicarb has just gone to 20, hardly any change. Sugars have gone up a little, but nothing really to tell us that patient is really bad. So it all comes down to what's the clinical state of the patient. Hyperglycemia can be considered as a poor prognostic factor, but the thing here is if they've started dextrose infusion, we won't know whether it's because of the drug or because of the infusion. So if there's hypoxia, then eventually heart failure. So these are all the things to consider, but investigations might not reveal this. So send other drug levels if required. So what's the initial management? What they had done outside was they had started normal saline, they had started a pressor, and they had started calcium gluconate. So always know how much drug you're giving. So when we dilute our norepinephrine in a 50 ml syringe, the concentration is around 0.2 mics per minute. So we're giving 8, comes to around 21, depending on how you're giving it, ml per hour, a minute, what your dosage is. And they gave a calcium gluconate bolus of 30 ml. But what's the right dose to be given? Depending on the drug, it varies. You've got to get calcium into the system. So the way you would treat a CCB toxicity is initially bolus is of fluid, calcium, atropine, and glucagon. That's the initial phase. Before you get the infusions loaded, getting everything organized, breaking ampules of calcium gluconate, all this takes time. The nurses have to sit and do. So initially you give boluses of these 3 drugs. Bolus of calcium gluconate or carbonate or chloride, atropine and glucagon, try to get the heart rate up. Then you start off all the infusions. So calcium infusion, high dose insulin infusion plus glucose, catecholamines, invasive BP monitoring is required. So this is probably one of the few indications where I'll say put the arterial line in the ER. So you'll have digital BP. Then other things that you can consider later are methylene blue, intravenous lipid infusion, ECMO if available, maybe a pacemaker. So it has to be a step-by-step process and it's quite intensive. So should we decontaminate these patients? Rule of thumb, pharmacology is pharmacological poisons. If they come within 2 hours, you can decontaminate. Activated charcoal within 1 hour for normal release tablets. If it's a delayed release tablets, sustained release tablet, you can give an activated charcoal up to 4 hours. But remember, this poisoning is so rare that we really haven't studied this. It's a a guesstimate based on pharmacology, the way the drugs act. Can we use these? So treatment options, like I mentioned, calcium chloride or calcium gluconate, insulin glucose, glucagon, vasopressor. So it would require, and a lipid emulsion, it would require the first 4 to start simultaneously. So you need to get central lines in place, keep a couple of IV lines also running. So all of this has to start simultaneously. Other complications, if you have a heart rate low, atropine boluses have to keep repeated. Pacing if they go into heart block, and if you have the capacity to start ECMO or get it organized, you have to keep that in mind. How do we give these individual drugs? So dosage of calcium gluconate and chloride can be quite complex. So this has to be organized before. You should know what to do. So calcium gluconate 10%, bolus you have to give 60 mg per kg. So that's around 0.6 ml per kg. That's the volume dosage of the ampule. Infusion around 0.6 to 1.2 ml per kg per hour. So the thing is, when you have that patient there, you don't want to sit and calculate how many milliequivalents are there, how many milligrams are there, how much we should give. So have it pre-calculated and kept. So 0.6 ml per kg bolus, 0.6 infusion, and titrate and increase. If you don't want to use calcium gluconate and you have chloride, chloride has a higher content of calcium. So there you can reduce the volume. And these can be, boluses can be repeated every 10 to 20 minutes depending on BP and heart rate effects. Pediatric doses also matter because nowadays children can also get access to these medicines. So again, the dosage there would vary based on kgs. So you give a slightly lower volume because the body weight would be different. So remember that calcium gluconate has around 9.3 milligrams or 0.45 milliequivalents of elemental calcium. So 10 ml ampule of calcium gluconate will contain around 93 milligram of calcium and 4.5 milliequivalent. Why this is important is most of the textbooks describe it like this. So you have to convert it from these milliequivalents to whatever drug you have, and then calculate and be ready with the dosage. Otherwise, you'll never get around to administering it. You'll be trying to figuring it out, what's happening, how much to give, and because this happens quite rare. So when do we stop calcium? So you have to monitor calcium every 30 minutes. So this is where point of care becomes really important. So you have to target at least 1.5 to 2 times the normal of the ionized calcium. So it's recommended every 30 minutes. So you need point of care. You can't send to the lab, get the report in an hour. It has to be done then and there. You get a calcium, keep checking and keep bolusing the patient. Otherwise, you lose heart rate and BP. Or the other thing you can do is immediately target a really high dose of calcium. If you can monitor regularly, keep bolusing. If you can't do that, it's not possible, then aim for a very high concentration of calcium. What's the normal level of calcium in our blood? Physiological? Right, 8 to 10. So 14, target at least double. So get there, because whatever you achieve will again drop. So you can treat until you have arrhythmias due to calcium now. That means you have to give so much calcium, you might precipitate in arrhythmia, or if you have signs of venous extravasation. So insulin, how do you treat? Again, insulin, we're used to giving 20 units, 30 units, but now you give these really high doses. 1 unit per kg IV, that's the dosage per minute or per hour we give. So that means 60 kg person will get 60 units per hour of insulin. These are huge doses of insulin because we're trying to manipulate that cardiac myocyte insulin pump to get more calcium in. So what happens here is you give that much insulin, the side effect of insulin is hypoglycemia. So you have to give an insulin infusion also. And if you, dextrose infusion, and you can't give 5% dextrose or 10%, you have to give huge doses. So you have to give at least a 25% dextrose infusion has to be started, or a lot of 10% dextrose. So the volume load on the body also becomes huge. So to remember, you've got one toxicity, you treat it with another, the side effects of that you treat with another. So that's what happens in calcium channel blocker toxicity. You have to keep catching up. So you'll be checking calcium, you'll be checking sugar, heart rate, BP. So the patient's blood sugar picking will be going crazy. But you have to keep doing this. It's very intensive. So glucose, like I said, has to be replenished, target at least 100 to 200, and higher concentration you have to keep giving. And remember, you give high glucose, you get thrombophlebitis, all of that starts. So what's the other side effect when you give so much insulin and glucose? Side effect of that, you get hypokalemia. So calcium channel blocker, to treat that, we overloaded with calcium and insulin. To treat that, we overloaded with glucose. To treat overload with glucose and insulin, we have hypokalemia, so you have to start a potassium correction as well. So sometimes you might have to put 2 central lines on this patient. Okay, because you can't give potassium again to the peripheral line because it will cause a lot of thrombophlebitis and pain, but usually patients are intubated and sedated by then. So you start a potassium infusion and make sure you give high concentrations of potassium. That means don't give 20 milliclins in 100 ml or 1 liter. You have to give like 80 milliclins in 200 ml. So high concentrations of potassium have to be given, because what will happen is the insulin glucose infusion will bring potassium down. So all of this is a play of physiology. If you know insulin glucose brings down potassium, and incidentally we use that to treat hyperkalemia. Whenever a patient comes with hyperkalemia, one of the drugs we start is insulin glucose. But now we've pushed that to the limit. So this goes on and on. So this is a newer therapy which is recommended for a lot of toxicological situations now, where we give an intravenous lipid emulsion. So when you give this lipid bolus, lipid is fat essentially, and it absorbs from the intracellular compartment into the intravascular compartment. So this lipid tank has been suggested for a lot of poisons nowadays. Again, this is not all evidence proven. These are all anecdotal reports, case reports, but it's a growing body of literature. So the recommended dose is around 1.5 ml per kg over 2 minutes, again bolus, and then you start an infusion. So the one thing about all these dosages, you will not have them on memory. Learn to use the internet and know how to get access to them. It's very hard to remember all these numbers. You can remember for the exam, but then when you finally come to practice, you forget. So have internet sources available so you know how to get them. And it's not a very expensive drug. It is sourceable. So what are the other indications for interlipid emulsion? This is something that, they've tried it in everything from OP poisoning to barbiturates. They're trying it everywhere. And, there's a good amount of use. So very popularly used in local anesthetic toxicity. So especially when they have reactions, you can use it there. But there's a possible benefit in a lot of other drugs, as you can see. A lot of beta blockers, some antipsychotics, cocaine, diltiazem. So, there are reports that it can be used in a lot of drugs and it has its advantages. So, this was the paper. So, another drug that you can use for bolusing is to give glucagon. Glucagon again acts on the beta blocker receptor. So, brings in calcium again. So, you bolus the patient with glucagon to keep the heart rate going up. So, you'll usually set up rules. Heart rate goes below this, give them a bolus of calcium. Heart rate goes below this, give them a bolus of glucagon. Goes below this, increase pressors, increase calcium. So all of these rules will have to be set and the patient will have to keep being watched. So this is something that's recommended, as if nothing else works, you can go in and ahead and try. You can try methylene blue. Vimal just told you how we all use it for methemoglobinemia. So this is something that can be tried. There are no great reports on it, but 1 to 2 mg per kg, you give it, and up to 6 hours you can try an infusion. In especially refractory cases, it's worth giving a shot. So these are all the medications that can be started. The patient will have a lot of lines, central lines, intubated. You have to monitor urine output, keep checking sugars, keep checking calcium, watch their acid-base balance. So everything will start. So what happened in our patient was, so patient came in around 6 o'clock. You can see on the chart, heart rate was around 70, 75, 80. Then 60, it was creeping down low. And, we started introducing we started insulin glucose and NORAD through a peripheral vein in the beginning. Then over an hour or so, we finally got our central line in, our heart line in. We shifted the norepinephrine to the central line because it acts better there. We gave the calcium boluses and started the calcium infusion. And even then, you can see that the heart rate was still, I hope you can notice, the heart rate was still between 65 to 75. We weren't getting a lot. Only after the calcium infusion started, we started getting some pickup in the heart rate, started coming to around 85, 90. And then finally, when we reached the calcium around 15.9, 16, we decided that was enough calcium and we were able to start tapering off the norepinephrine. And we stopped the calcium because we didn't want it too high. So then what happened, this was our heart rate trend. This is what happened. Over a period of a good 12 hours, this is all that we were able to manage, a heart rate of 96. BP had stabilized. So this was the treatment. What I just mentioned to you is the same thing again and again. All of this was going. But then eventually we started having a situation where the BP started dropping again, the heart rate started dropping again. You can see calcium, we were able to hit really high levels of 15 and 17 and everything. But eventually what happened was the BP started crashing again. So at that time, we decided to go ahead and try lipid emulsion boluses. So we gave one lipid emulsion bolus. Calcium was around 12.2. Then we gave another one. We started in the early morning time. Over the night we treated, and when we started seeing the BP drop again, we started giving lipid emulsion boluses. And that bolus actually, it delayed restarting calcium. We could have avoided that. We thought too much calcium. So that's the one thing we tried on this patient. After that, we found it very useful. And in spite of calcium being given, then the calcium started going really high. So we felt that this was the lipid emulsion that was helping us here, and we didn't need that much calcium. After 24 hours, we were able to come back. Still, heart rate isn't really high. It's still around 70, 60, it's around that much only. But we had a normal sinus rhythm by now. That means we had gotten the P wave back. And, we marked that as, okay, we're achieving some physiological stages we're bringing back. So PR was still prolonged at this time, but we had gotten the P waves back, but it was definitely an improvement from what we started with. So the learning lessons in this case was, the intensive portion of handling the case, that was the hardest thing. Multiple infusions going, every treatment had a complication, and you have to keep doing it. It goes to such a point that, you run out of insulin. You run out of dextrose, the 25% dextrose bottles you run out. You have to keep stocking this to keep the patient afloat. And the lipid emulsion is something that we tried. This was the first case that we tried, and after that, we've used it several times, and we've had shorter ICU stays with these patients. So that's the learning lesson that we took back home. And glucagon, which is not regularly available, we were able to source it and use it. All of this lowers the calcium infusion, the amount of calcium that you have to give a patient. So the one thing I'd like to tell you about calcium channel blocker poisoning is there's not a large body of evidence that's out there. And most of the case reports and everything that come, unfortunately, come from the Middle East, India, and the Southeast Asia, where there are over-the-counter drugs. Anywhere in Europe and the West, to go get a new calcium channel, you have to go to your physician, they'll give again. So the risk of overdose is lower there. Can happen if it's a fresh sample, but in India, it's easily available. And many times we found that the people who've taken these medications, it's not even their drug, it's their grandmother or somebody else's drug, and they've taken it. Okay. The one thing that we should do to learn more about this poisoning, we need to grow registries. It's where I get 2 cases a year, you guys get 1 or 2 cases, Vimal gets 3, 4 cases. Only when we combine will we grow a body of understanding to understand how to treat these toxins. Until then, we're still following very anecdotal evidence. Thank you.
Thank you, Girish Narayan. Yes, nice to see you. It's a really nice presentation. So integrated medicine. So you made the things very easy and well presented. So you mean to say everyone need to know a physiology, pharmacology based strong. So that makes the emergency medicine fruitful. Yes. So with the toxicological base, you already highlighted many drugs. It's really fantastic. So one recent one you are told lipid emulsions. So find those. Is it FDA approved for the treatment purpose?
It's FDA approved. It's not trialed.
They is under the trial.
No. It won't get trialed because you can't do an RCT with it. It's approved.
Is that
it's approved?
Okay.
It's but nobody's done a randomized controlled trial.
Fine.
So it's only if you grow a body of evidence will the recommendation come.
Exactly. So you are with the reverse pharmacology.
Yeah,
So,
we have to.
fine. So that's what anyone would like to. Yes, it's really good. So I'm also alumni of the same college, UG or the PG. That's it. Fine. Anyone? Any question from the audience?
Any question from the audience? Okay, thank you.
Thank you.
Thank you so much, sir, for emphasizing on the topics in such a wonderful way. Now I would request our chairpersons, Dr. Sudha Sahu ma'am and Dr. Nalini ma'am to felicitate our esteemed speaker. Now I request Dr. Vinutha ma'am and Dr. Sridevi ma'am to honor our chairpersons.
Faculty podium presentations.
Thank you so much, ma'am. Now we'll be continuing the session with the faculty podium presentation over here itself.
We have our first faculty presenting a paper, Dr. Raghavendra sir. ID number 025. Faculty podium presentations, ID number 025. And for the faculty podium presentations, I call upon Dr. Krishnadath Chavali sir and Dr. Rakesh Goria sir to judge the session. You'll judge from this, sir. I'll just read out the judging criteria, how it is allotted for your information. The uniqueness of topic here is 5 marks, presentation skills for 5 marks, appropriate use of AV aids for 5 marks, time management for 5 marks, and response to the questions 5 marks. And it's totally amounting to 25 marks. We have our first presenter, Dr. Raghavendra R. Sir.
A warm greetings from Sri Matsuan Sai Institute of Medical Sciences and Research. Good evening, one and all. I'm presenting a case report, the pit-viper connection, hypopituitarism following viper envenomation. I'll start with a brief introduction. As we all know, this viper envenomation is common in Indian subcontinent and Southeast Asian countries. And features of this envenomation includes coagulopathy, shock, acute kidney injury, neurotoxicity, and local tissue damage. This can lead to significant morbidity and mortality. Here, we describe a rare complication of systemic envenomation following a viper bite. Case report. A 34-year-old single, farmer by occupation, was brought to our hospital with a history of viper bite over his left leg, Toller's back. He had a severe pain at the site of bite, but no swelling and no bleeding. Subsequently, he developed oliguria. Fluid resuscitation and anti-snake venom were administered. Subsequently, he developed anemia, thrombocytopenia, and evidence of intravascular hemolysis. And his peak serum creatinine was 7.2 milligram per deciliter. Hemodialysis was initiated to correct his hyperkalemia, acidosis, oliguria. And this patient received multiple packed RBC transfusions, antibiotic, and other supportive measures. And patient recovered from acute renal failure gradually, and his serum creatinine was at discharge 1.8 milligram per deciliter. However, he continued to feel unwell with lethargy and anorexia. He also had nausea, vomiting, and had lost weight significantly in next 3 weeks. So there was no history of head injury or surgical intervention or any radiation in the past, as his family brought him for the further evaluation and the management. Patient had a good urine output and had significant postural giddiness. Patient had inability to get up from a sitting posture and was unable to walk without support. And he was admitted for evaluation to rule out underlying CKD. On examination, middle-aged male, emaciated, wrinkled skin, looks older for his age. He was anemic and tachycardic. Blood pressure was 96/60 millimeter of mercury in supine position with significant postural drop. His secondary sexual characters were preserved. He had significant proximal muscle weakness in legs. Systemic examination was otherwise unremarkable. So preliminary investigation revealed anemia. Thyroid function test suggested central hypothyroidism. The TSH, T3, T4 all were decreased, which led to the anterior pituitary hormone assay and MRI pituitary. So pituitary function test revealed deficiencies of steroid, thyroid, and gonadal axis. Since 9 AM, plasma cortisol was very low, 2.8 microgram per deciliter. Neither a short synactin test nor an insulin tolerance was performed. The MRI revealed partial empty sella. So final diagnosis was made, delayed hypopituitarism secondary to Viper envenomation. Coming to treatment, he was treated with the hydrocortisone 10 milligram at 7 AM, 5 milligram at 1 PM, and 5 milligram at 5 PM, and thyroxine 100 microgram, and testosterone enanthiate by intramuscular injection 250 milligram every 4 weeks given. And he improved dramatically over the next 3 to 4 days, and he could walk on his own. And he was discharged and remained asymptomatic till date. Coming to discussion, the first case of snake bite causing anterior pituitary dysfunction was described by Wolf, where the person had bitten 7 years previously by Jararacucu in Brazil in 1958.